Hi everyone, very good evening to each one of you. Myself Dr. Vaibhav Jain, and this is your Oracle 90 days foundational live classes for university exams. Right? In this particular section, we are going to discuss about the autocoids today. So we are going to learn about the autocoids, what are the important things, right? Apart from that, these classes are going to be beneficial for your university prof exam as well as for your next exam, right? What we are going to do today, we are having long essay questions, short essay questions, and short answers, where we are going to discuss about the important topics that can be asked from this particular part, right? Next thing we are having why to choose Oracle, why to choose Oracle. Oracle application has recorded classes, live classes, but the exclusive feature that you will get is your practical sessions. So there is a mentor who is going to guide you for all the practical sessions that are going to happen, right? Apart from that, we are having this exam module where you will be having the rapid revision that you can watch just before your examination. So this is going to be very helpful, right? And you will also get the hard copy notes that are going to be colorful notes helpful for your revision purpose, right? We are having like foundation classes where you will be getting the application, right? When you are going to the hospital, or maybe you are going to the lectures, right? What you will be doing, you will be understanding the topic. After that, if you are having any difficulties, you can always come back to our application. You can always revise things with the experts, right? We are having this flexible mode of learning, so whenever you wish to study, you can always study, right? We are having live classes just like this. We are conducting live classes, so you will be getting all the information from the excellent faculties that you are having. That is going to be your live classes where you can ask your doubts as well, right? We are having express exam module that is going to be for the 20 hours rapid revision that you will see just before your examination. In fact, I have covered the pharmacology within 20 hours for the exam purpose, right? Apart from that, you are also getting the one-to-one doubt clearing session, because lots of students cannot directly interact with the faculty, right? So they can directly ask the question, whatever doubts they are having, they can directly connect with the faculty. And definitely you will be getting the hard copy notes which are going to be helpful for your revision purpose, right? And you will be getting the question bank so that you can assess yourself where you are standing, right? You can always check yourself. You will be getting MCQ examination after your prof examination. You will be having like PG examination, or some of you are going to appear for the FMG examination. So for both the purpose, these question bank are going to be very helpful. Whatever you have studied, you will be coming back, you will be coming to the question section, and then you will be solving the questions, understanding what you know, what you don't know. Okay, so these are the things you can get, right? We are also having the practical sessions where where the faculties will guide you about how to do the practical, how they will be showing you everything, right? That is going to be a very helpful thing. We are having our subscription plan, we are having foundation plan, we are having this advanced learning plan, we are having complete learning plan, and ultimate MBBS plan, where you will be getting connected with us throughout your MBBS journey. That is going to be your ultimate MBBS plan. Here you will get the one-to-one doubt clearing session. Here also you will get the one-to-one doubt clearing session if you are buying the subscription for 1 year. These are the plans. These are your advanced learning for 6 months and foundation for 3 months, right? So these are the plans. You can always subscribe, right? And you can always use my code that is going to be your Dr. Web of Gen 20, and you will get the discount, 20% discount, right? So that was the brief introduction about Oracle. Now we are going to discuss our topic. The topic of choice for today is going to be your auto quiz. So what are these auto quiz? Simple understanding, guys. Whatever things which are coming from the autocrine gland, they are known as autocoids. So autocrine glands are those glands which are working locally. They are producing the local effect. Endocrine are going to produce the systemic effect. Like endocrine will be releasing their substances directly into the blood, and blood is the connective tissue. It is transporting things all around the body. So that is the connection part, right? So that is going to be the endocrine. This is going to be your autocrine. We are having like histamine, serotonin, prostaglandin. All these things are going to be coming under your histamine, your serotonin, your prostaglandins, your bradykinin, leukotrienes. So all these things are going to come under this particular chapter of autocoids, right? So we are having a case. Let's try to understand the pattern of examination is changing now. Nowadays, you are not getting a direct question. You are getting integrated question. If you are going for next examination, so that would be an integrated exam. So you have to develop this technique, right? You have to study in the way that everything is in the horizontal way. That means you connect other subject as well. So what is the question we are having? The case that we are having, there is a 37-year-old woman presented to the physician with the complaints of intermittently occurring joint pain. This particular female is having what? Joint pain in her wrist joint is involved, ankle joint is involved since 6 weeks. 6 weeks means, it means around 2 months, right? Further questioning revealed that she had been experiencing occasional morning stiffness. These are the key words you have to always look for. Sorry. Morning stiffness and a tingling sensation in her extremities. These are your sensations in your extremities you are finding. She denied of any headache or other symptoms except mild fatigue. Mild fatigue is also a symptom. On physical examination, the patient expressed mild tenderness in both the wrist. There is a tenderness on the wrist. The blood test revealed positivity for anti-CCP, and this anti-CCP is very, very characteristic for which particular disease. Yes, patient is having joint pain more than like 2 months, right? Patient is having morning stiffness, and that pain will be reduced by the evening. So morning stiffness is a very characteristic thing. Involvement of small joints, that is going to be very characteristic for a particular disease that is known as rheumatoid arthritis. That this particular patient is having what? Rheumatoid arthritis. Is it possible to cure rheumatoid arthritis? No, it is not possible, right? We can just delay it. We can delay the course of the disease. We cannot directly cure it, right? So this is your anti-CCP antibody, which is going to be positive in the cases of rheumatoid arthritis, right? So let's try to understand what is this rheumatoid arthritis. Long as a question, so let's try to summarize. Let me summarize it for. So what is rheumatoid arthritis? Rheumatoid arthritis, remember, it is a autoimmune disease. Rheumatoid arthritis is a autoimmune disease. What are autoimmune diseases? That means immunity is formed against the self, right? So here this particular patient is having autoimmune cells. It is an autoimmune disease. That means body is body is causing the disease to himself, right? So this is going to be autoimmune disease. What is going to happen? You will be having formation of immune complexes. You will be having formation of immune complexes of IgM antibody. IgM is going to be for the acute infection, and this IgM is going to activate your which complement? It is going to cause activation of complement system. It is going to cause activation of complement system, and once there is activation of complement system, there will be release of certain cytokines. Release of cytokines. What are these cytokines? Once you understand the physiology or pathophysiology around it, treatment will be easy. So there will be release of cytokines. What are the cytokines? Like TNF alpha, tumor necrosis factor alpha. We are having like interleukin 1, interleukin 6. So these are the cytokines which are going to come out. And these cytokines are going to cause WBC. They are going to bring WBC, or you can say neutrophils or lymphocytes. And this WBCs are going to cause what? They are going to release certain enzymes. What are these enzymes? These are your lysosomal enzymes. These are going to be your lysosomal enzymes. And these enzymes are going to do two things. First thing, they are going to increase your prostaglandins. They are going to increase your prostaglandins, and you already know the function of prostaglandins, what I've taught you. It is going to cause pain, it is going to cause fever, inflammation. So here in this particular case, it is going to cause pain and inflammation. It is also responsible for the vasodilation, right? These are the functions of prostaglandins, right? And this these lysosomal enzymes, they will do one more thing. They are going to do the destruction of small joints. Destruction of small joints, like your ankle joint, like your knee joint, or not knee joint, like your elbow joint, small joints. And they are also going to affect your cartilage. So they are going to do the destruction of small joints and cartilage, like joints of your hands, fingers, and feet. So this is going to be the pathology. This is going to be the problem in the rheumatoid arthritis. What is going to happen? It is an autoimmune disease where you will be having formation of complexes of IgM. These complexes activate your complement system, and they will be releasing these particular things, TNF alpha and interleukin 1 and WBCs. When these WBCs, TNF alpha, interleukin, they are going to activate your lysosomal enzymes, you will be having destruction of small joints and bones, right? So that is going to cause the pain in particular patient, right? Apart from this prostaglandin is also responsible for pain and inflammation. So if I close this prostaglandin, if I close this lysosomal enzymes, if I close this TNF alpha interleukin 1, what will happen? The disease will be delayed. We cannot directly cure it completely, but yes, we can get the relief in the patient, right? So for the acute course, let's try to understand, if some, for the treatment purpose, if someone is having pain, for the acute relief, what you can do, you can give NSAIDs to the patient. NSAIDs are the drugs which are going to block the prostaglandins, non-steroidal anti-inflammatory drugs, right? They are going to block the COX, and you will be having what? Decrease in the pain, fever, inflammation. What are the examples? You can use drugs like aspirin. But sometimes if these drugs are not effective, you can use COX-2 inhibitors as well. COX-2 inhibitors like your celecoxib. Celecoxib we are not using very commonly, but we are using etoricoxib. Etoricoxib, which is a COX-2 inhibitor. And this etoricoxib will be working for full day. You need to take the drug once in a day. That is going to be OD drug, right? Even if this is not working, then you can give the steroids to the patient, because steroids are the choice, right? Steroids you are giving in the autoimmune diseases, right? So what is going to happen? You are going to give steroids, like you can use injection of triamcinolone. Triamcinolone. You can give intra-articular injection of intra-articular injection to the small joints. If more joints are involved, like if more than 3 or 3 to 5 joints are involved, you can do what? You can give oral steroids as well. Like we are using omnacotil, that is nothing but your prednisolone. So we can use oral prednisolone, which is a glucocorticoid. Prednisolone, which is a glucocorticoid or steroid, right? Now, in the cases of chronic, so this is going to be for the treatment of acute rheumatoid arthritis. But for the chronic cases, what you can do, for chronic or long-term cases, what you need to do, you need to use certain drugs. What are these drugs known as? These are known as DMARDs. These are known as DMARDs. Sometimes they are also known as SARDs. What is DMARD? Disease modifying anti-rheumatic drugs, right? What is SARD? Slow acting anti-rheumatic drugs, right? So these are going to be DMARD and SARD. So we are having two types of drugs in this particular class. We are having conventional DMARD. We are having biological DMARD. What is this conventional DMARD? So we are having two types of drugs. We are having conventional drugs. We are having biological drugs. Biological drugs. What are these conventional drugs? Remember, we can use drugs like immunosuppressant. What do we want? What do we want in this particular case? We want our immune system to get suppressed. If I suppress my immune system, what will happen? You will not have activation of complement. You will not have lysosomal enzymes. You will not have those WBCs. Those cytokines will be not be there, right? So we just want to delay the disease, and for delaying the disease, we can give immunosuppressants. So what are the immunosuppressant drugs we are having? Like we are having drugs like methotrexate. Methotrexate. In fact, you can remember methotrexate is the drug of choice, right? We can use drugs like azathioprine. We can use drugs like azathioprine. We can use drugs like cyclosporine. Cyclosporine. These are your immunosuppressant drugs. We are also having immunomodulator drugs, right? We are also having immunomodulator drugs. What are the immunomodulators that we are having? We are having sulfasalazine. Sulfasalazine. Can you try to answer? Please try to answer. These are important things. Try to answer. Where do we use this sulfasalazine? Sulfasalazine is in fact the drug of choice in one more disease that we have discussed. Yes, that is going to be your inflammatory bowel disease or ulcerative colitis, right? So that is going to be your sulfasalazine, sorry. Right, we are having next drug that is going to be your hydroxychloroquine. Right, we are having drugs like leflunomide. So these are your immunomodulators, these are your immunosuppressant. We just want to decrease our immune system. Second class of drugs that we are having are going to be your biological agents. So biological also we are having two classification. One is going to be your TNF alpha blocker. One is going to be your tumor necrosis factor alpha blocker, TNF alpha blocker, right? So these are going to be your TNF alpha inhibitor. What are the examples we are having? You can remember the drugs like etanercept. You are having drugs like infliximab. You are having drugs like adalimumab. Previous year question, adalimumab. So we are having drugs which are TNF alpha blocker, etanercept, infliximab, and adalimumab, right? What other drugs you can use? These are going to work specifically. These are going to be your anakinra. First one, anakinra. Anakinra. We are having drugs like abatacept. We are having drugs like rituximab. So what we have studied till now, let's try to summarize everything. So if the patient is having rheumatoid arthritis, patient will be having involvement of the small joints, right? This is an autoimmune disease. So we cannot just directly cure it. We just want this particular disease to decrease the symptom, right? We can give the symptomatic relief to the patient. If the patient is having acute symptom or acute flare, what we can do, we can give NSAIDs to the patient. We can give aspirin to the patient. If patient is not recovering, we can give it toricoxib, right? That is the COX-B inhibitor, right? Then we can use steroids. Then we can do long-term classification of drugs. We are having conventional DMARDs, we are having biological DMARDs. In conventional, I can suppress the immune system with the help of immunosuppressants. These are going to be your methotrexate, azathioprine, cyclosporine. We can use immunomodulator drugs, sulfasalazine, HCQS, and leflunomide, right? Biological agents that we are having are going to be important one I'm discussing here, right? These are going to be your TNF alpha blockers like etanercept, infliximab, and adalimumab. Other drugs we are having interleukin 1 inhibitor, that is going to be your anakinra. We can use abatacept, we can use CD20, that is going to be your rituximab. So these are the drugs we are using in the cases of rheumatoid arthritis. Now let's try to understand. Let's begin with the methotrexate. What are the important points about this particular drugs? Some important points I'm writing over here. This is going to be about the methotrexate. Remember, this methotrexate is in fact the drug of choice for rheumatoid arthritis. How it is going to work? It is going to inhibit your dihydrofolic acid reductase, DHFR. It is going to inhibit your DHFR, leading to increase in the adenosine. Adenosine, very, very important, adenosine increase. And remember, whenever we are having increase in the adenosine, it is going to exert anti-inflammatory effect. It is going to exert anti-inflammatory effect. So you will be having this anti-inflammatory effect because of this methotrexate. And in fact, this methotrexate is an anti-cancer drug as well. So we are using in little dose, in a smaller dose for 2 to 4 weeks we are using. And this anti-inflammatory property you will be getting very important after 2 to 4 weeks, right? So these are the things you have to remember. Apart from that, there are certain side effects of this methotrexate. It can be hepatotoxic. Hepatotoxicity is a component that you have to check within like 3 to 6 months. You have to check for the hepatotoxicity. You can check for the liver function test. This is a anti-cancer drug, and I have already taught you all the anti-cancer drugs. They are going to kill what? They are going to kill the rapidly growing cells in the body. So this is going to cause what? Bone marrow suppression as well. So bone marrow suppression is going to be another side effect of this particular drug. This is also nephrotoxic, guys. This is also nephrotoxic. So these are the components you have to remember. If someone is having kidney damage, we are avoiding the methotrexate. The next important drugs that we are having is going to be hydroxychloroquine. Hydroxychloroquine. They can ask you question based on this because this is the drug we have used in the COVID-19 as well. So what this particular drug are going to do, they are going to remember stabilize the lysosome. And if lysosomes are stabilized, what is going to happen? Look here. If lysosomes enzymes are stabilized, there will be decrease in the destruction of small bones, right? There will be decrease in the prostaglandin, there will be decrease in the symptoms. You understand why it is important to understand the pathology, right? So what it is going to do, it is also going to do inhibition of WBC proliferation, inhibition of WBC proliferation, lymphocyte proliferation will be inhibited, right? Important question that they are asking is based on the side effect. What is the most important side effect that you can get from this particular drug? Is remember bull's eye or macular edema. You can remember macular edema is a very important side effect that you will be having because of hydroxychloroquine. The next important drug is going to be your sulfasalazine. Sulfasalazine. I've taught you this particular drug in the cases of ulcerative colitis also. Right, this is a 5 amino salicylic acid derivative. It is a 5 ASA derivative. And what it is going to do, remember, it is also going to inhibit the lymphocytic proliferation. It is going to inhibit the lymphocytic proliferation. Lymphocytic proliferation, beta. Proliferation. If there will be less lymphocyte, there will be less inflammation, right? And this is the same mechanism it is going to utilize in the cases of ulcerative colitis. Ulcerative colitis, you will be having involvement of rectum. Patient will be having fresh bleeding, and because of damage to the mucosa, what is going to happen? If the mucosa will be damaged, the patient will be having excessive movement, right? I've taught you in the GIT section, if there is any disruption in the mucosa, it will be having hypermotility, and this hypermotility will lead to what? It is going to lead to diarrhea in the patient, and the patient is going again and again for the diarrhea. There will be ulcer formation. That is what is happening in the ulcerative colitis, right? So to decrease that, we are giving this sulfasalazine. In fact, it is the drug of choice, and this is going to decrease the inflammation. This is going to decrease the motility. This is going to decrease the basically, and it is anti-inflammatory thing. So if it is an anti-inflammatory thing, what is going to happen? There will be no WBC proliferation. There will be decrease in the movement, right? This is why it is going to be protective drug, right? So now we are going to discuss about the TNF alpha, the important properties about the TNF alpha blockers. So we are having this TNF alpha inhibitors or TNF alpha blockers. Remember, they are given by subcutaneous route. Two exception you have to remember, given by subcutaneous route. What are the two exceptions you have to remember is going to be your infliximab and adalimumab. Infliximab and adalimumab. Remember, we are going to give it via IV route. IV route. But there are some specific conditions you have to take care while giving this TNF alpha blockers. If someone is having granuloma formation because of like hepatitis or because of TB, some cavities are there. This particular drugs can cause reactivation of the old TB or reactivation of the old granulomas or reactivation of the old hepatitis B, right? You have to remember this, right? This particular drugs can cause GI ulcers. They can cause GI ulcers. They can cause reactivation of sorry. They can cause reactivation of hepatitis B. In fact, or TB. And in fact, these things can cause skin cancers. They can also cause skin cancer, so you have to use them very cautiously. Then we are having some specific drugs like interleukin 1 inhibitors. I've taught you interleukin 1 and TNF alpha are the important things, right? So, what is the drug that is going to work on interleukin 1 inhibitor? That is going to be your anakinra. Kinra. So you can remember this is the interleukin 1. You can remember 1 from E. That is the drug you will be using, anakinra, used in rheumatoid arthritis, RA. You can remember like that. Next drug we are having is interleukin 6 inhibitor. 6, you can remember 6 for Sari. Okay, so that is going to be sarilumab. Sarilumab. And one more very important drugs that you have utilized in the cases of COVID-19. In COVID-19, you have utilized the drug that is known as tocilizumab. Beta. Tocilizumab. Tocilizumab is a drug that we have used in the cases of COVID-19 to prevent the cytokine storm. What is the thing it is doing? It is decreasing the risk of cytokine storm. So it is going to decrease the cytokine storm. That is why we are using these two important drugs. They are very costly, right? So these are the two important drugs you have to remember. Interleukin 6 inhibitor, that is going to be 6 for sarilumab. You can make 6 like that, right? Or S for 6, that is going to be sarilumab and tocilizumab. The next one in the list is going to be CD20 inhibitor. CD20 inhibitor, name of the drug is going to be your rituximab. Rituximab. One more you can remember is going to be your abatacept. It is going to work on CD80 or CD86. It is going to work on CD80 or CD86, and it is going to do what? Down regulation of. It is going to do down regulation of T cells. It is going to do. Remember, it is going to do down regulation of T cells. It is going to do down regulation of T cells, and if there is down regulation of T cells, what is going to happen, beta? You will be having decrease in the T cells, decrease in the immune cells, leading to what? It is going to show you again anti-inflammatory effect. Again, it is going to show you anti-inflammatory effect. Anti-inflammatory effect. So these are the important drugs that we are using, beta. These are the important things that we are discussing. We are using very, very important question that you can get in your examination. Very, very important topic, right? This is your rheumatoid arthritis. I've taught you about the basic physiology, basic pathology, why it is happening. Now you understand we can block TNF alpha blocker. We can give interleukin 1 inhibitor, anakinra. We can give interleukin 6 inhibitors. We can give drugs which can block the proliferation of WBCs. We can inhibit this lysosomal enzymes, right? So ultimate purpose is to delay the disease. Ultimate purpose is to delay the destruction of the joints that we are having, right? So for this particular purpose, I have given you certain drugs, like we are having conventional drugs, we are having biological drugs, right? Next topic that we are going to discuss is about the histamine. So this is a short essay question. We are having histamine. How many types of histamine do we have? What are the different receptors we are having? What are the actions, indications, adverse effect? Let's try to understand. First of all, let me make you understand this histamine is going to be coming from where? What is the source of histamine? It is going to come from histidine. Remember, histidine is the source for histamine, and this histamine, which is formed, is going to be stored in the. It is going to be stored in the form of stored in mast cells. It is going to be stored in the mast cells. It can be non-mast cell histamine. We can have non-mast cell histamine also, but generally it is stored in the mast cells, right? We are having different receptors, and because of those receptor, we are having the action. So what are the different receptors we are having? Let's to make a note. First one, we are having H1, we are having H2, we are having H3, we are having H4, right? These are the four important receptors we are having. So remember, H1 is going to be causing what? It is going to cause bronchoconstriction in the bronchus. It is going to do constriction. Second thing, it is going to do vasodilation. That is why vessels are dilated, something will be coming out. That is going to give you red appearance whenever you are having like any case, be it urticaria, be it a mosquito bite, formation of a wheal. Every time the same story will happen. There will be vasodilation. If there is any vasodilation, something will be coming out leading to red appearance. Okay, so you will be having this vasodilatation, right? It is going to increase your GI contraction. It is going to increase your GI contraction. It is going to be responsible for the wakefulness also. In the mammillary bodies and the in the brain, we are having the histamine receptor, and they are going to be responsible for the wakefulness. They can also cause what? Itching in the body. So these are the functions of histamine, right? H2 receptor, remember this H2 receptor is going to be responsible for increase in the heart rate, increase in the contraction of heart, and most importantly, it is going to be increasing the HCl production from the parietal cells. Increase in the HCl production from the parietal cells. I've taught you three things for the increase HCl. First thing is acetylcholine. Second thing is H2 receptor. This is your particular H2 receptor that we are having. And the third thing is going to be G cells releasing what? Gastrin, right? This H3 receptor are going to be responsible for what? This H3 receptor is going to decrease your H1 and H2. These are going to be your present on the neuron, right? So this is going to decrease your H1 as well as H2, both the receptor. And this H4 is responsible, you must have studied in pathology, that is going to be responsible for the chemotaxis movement, right? So these are the receptors that we are having. We are having H1 receptor, we are having H2, H3, and H4 receptor. And these four receptor are going to exert certain effects, right? So let's try to understand what are the effects that you will be getting because of these receptors, right? And if I'm going to block all these receptor, the drugs are known as antihistaminic drugs. What are the name of these drugs? These are known as antihistaminic drugs. Antihistaminic drugs. So we can use antihistaminics which are going to inhibit your H1 receptor. So we can use H1 blocker, we can use H2 blocker, we can use H3 blocker, and we do not have any drug for H4 blocker, but for the remembrance purpose, let's write it down. So H1 blocker is going to be utilized in the cases of allergy. If the patient is having allergy, you will be using antihistaminics. That is going to be H1 blocker. Even in the cases of motion sickness, you are using what? In the cases of motion sickness, you are using H1 blocker. If I want to give you some examples, we are having examples like we are having drugs like Benadryl, or you can remember diphenhydramine, and which is nothing but your Benadryl. We are having drugs like Phenargan, or you can also call it promethazine. We are having drugs like cetirizine, levocetirizine. So all these drugs are going to be utilized in the cases of H1 problem, right? What is this? H1 is going to do bronchoconstriction, vasodilation, GI contraction, wakefulness, and itching, right? So these are the functions. H2 we are generally using in the cases of peptic ulcer whenever we are having full stomach. Whenever we are having full stomach, patient has already eaten something. We should not give PPI, right? In this particular case, we are using H2 blocker. The examples are your cimetidine, nazartidine, famotidine. All these drugs are going to be ranitidine or famotidine, right? Famotidine or nizatidine, whatever you want to remember. Famotidine group of drugs. These are the drugs we are using for the H2 blockade purpose. H3, remember, it is going to block H1 and H2 together. It is going to decrease the action of H1 and H2. So we can use this particular thing in the cases of wakefulness. To increase the wakefulness, we can give H3 blockers. The name of the drug is going to be Pitolisant. The name of the drug is going to be your pitolisant. And this H4, we do not have any drugs. We have not made any drugs around it, right? This is for the chemotaxis purpose. We do not have any drugs for this, right? What are the specific side effects that you will be getting because of this antihistaminics? You can get sedation, you can get dry mouth, you can have epigastric distress. In higher doses, it can even cause tremors. It can cause flushing in the body, flushing because of vasodilation. Bronchoconstriction can lead to Bronchoconstriction can lead to dyspnea. Patient can even have hypotension. And these are the drugs, like you can remember, we are having a class in the anesthetic, we are having curare and coronium group of drugs. So what are those curare group of drugs? They are histamine releasers. They are CVS unstable. So histamine releasers, what people used to do in the ancient time, they used to use suin or needle poison. So what they are doing, they are putting that particular curare and then they are injecting it to the animals. What is going to happen in the animal? It is going to cause the anesthetic effect, right? It is going to cause the muscle relaxation, right? Animals cannot run. Second thing, it is going to release lots and lots of what? Lots and lots of histamine that is going to cause bronchoconstriction in the patient. In the animal patient, the animal will be having hypotension and he will be dying, right? So these are the things you have to remember about the histamine, right? Next, we are having first generation and second generation antihistaminic drugs. So H1 is further divided into H1 blockers are further divided into two classes based on what? Based on one important thing, that is going to be whether they are able to whether they are able to cross your blood brain barrier or not. If they can cross their blood brain barrier, they are going to cause what? If they can cross blood brain barrier, that means they can go to the brain. If they can go to the brain, they can produce what? They can produce sedation in the patient. So if the drug is going to the brain, it can produce what? Sedation in the patient. Okay. So if patient is sedated after taking antihistaminics, patient is having itching, patient is taking some drugs and he is feeling lethargic or drowsy. What you should be thinking, this particular patient should drive. No, this particular patient should not drive. So this particular drug we are avoided or contraindicated in the cases of children, or in the pilots, truck drivers, be it your any driver, pilots or any drivers you can remember. So anyone who is using their brain or who is working with full focus, you should not give this particular drug because they are going to cause what? Sedation in the patient. Okay. Apart from the sedation thing, they are also having one more important property. They are having anti-muscarinic effect. They are having anti-muscarinic effect. And what we have studied in the muscarinic system is about the what are the muscarinic receptor M1, M3, M5, M2, M4. They are going to cause different things, right? And these are going to have anti-muscarinic effect, or you can also call it anticholinergic effect, right? Something like anticholinergic effect will be there, right? What are the examples you have to remember from the first generation? First thing you can remember is diphenhydramine. Diphenhydramine. Diphenhydramine, or you can also remember Benadryl. Benadryl is the cough syrup that we are using. And what is the side effect you will be having? The patient will be feeling drowsy or sedation. Those of you who have taken Benadryl, you must be knowing that after taking diphenhydramine, what will happen to you? You will be feeling sleepy. This is your first generation antihistaminic drug. Why? Because it is going to your brain, blocking that H1, causing what is the H1? H1 is responsible for the wakefulness. Now you are feeling drowsy. Okay. Second thing that we are having is going to be your promethazine. Remember, let me write the preparations also. So this promethazine is coming in the market with the brand name of Phenargan. Phenargan. You can also call it Phenargan. Remember, this is going to be utilized in the cases of extrapyramidal side effects. In the cases of extrapyramidal side effect after antipsychotic drugs. It is also be used in the cases of motion sickness. I've told you well in the detail what is this motion sickness is going to happen, right? So this motion sickness, we are having another drugs like hydroxyzine. It is coming with the brand name of Atarax. Atarax. This is going to be antipruritic agent. Antipruritic agent. This is also having some anxiolytic effect. Anxiolytic effect like benzodiazepine. It is also going to depress your brain, and we can use this hydroxyzine in the children's, right? They are not sleeping, they are having itching, right? We can use it. Then we are having drugs like phenarmine. Phenarmine. This phenarmine is coming in with the brand name that is going to be your Avil. Avil we are using sometimes after some drug reactions. What is happening? Patient is having some allergic reaction. In that particular case, we can use Avil. Along with sometimes we need to use what Dexona, that is going to be your dexamethasone, nothing but the steroid, right? We are having other drugs like Synargine. Synargine. These are all. This is coming with the vertigo, the preparation of vertigo. And remember this Synargine we are using for the cases of vertigo. This is what we are using for vertigo patient. If patient is having vertigo, we can use Synargine. We are having other drugs like chlorphenarmine. Chlorphenarmine. This is what you are also finding in the anti-cold preparation. In the anti-cold preparation, you will be having that chlorphenarmine, right? Chlorphenarmine malate. Remember, this is going to cause least sedation. This is going to cause least sedation, beta. We are having other drugs like cyproheptadine. Cyproheptadine. This cyproheptadine is going to block your 5-HT2, and this is also going to increase your appetite. This is also going to increase your appetite. Cyproheptadine. One more important drugs that they are asking you is going to be doxylamine. Doxylamine. Along with the vitamin B6, we are having some preparations, and that is what is going to be used for the drug of choice in the cases of morning sickness. And remember, this is going to be the drug of choice for morning sickness, along with vitamin B6. Then we are having drugs like cyclazine. Last you can remember miclazine, cyclazine. They are used for the motion sickness. They are also used for the motion sickness, right? So they are having anti-muscarinic effect also. So these are the first generation antihistaminic drugs. Remember how they will be asking you question. They will be asking you question. What are the first generation? What are the second generation drugs, and how they are differentiated? So I have given you great details. You will be understanding this particular things, right? Diphenhydramine, Benadryl, promethazine, that is going to be orphanargan, hydroxyzine, that is going to be Atarax. Uses I've told you, right? We are having Synargine for the vertigo, right? Chlorphenarmine you are finding in the anti-cold preparation, cyproheptadine for the appetite also, and 5-HT2 blockade, doxylamine drug of choice for the morning sickness, right? And cyclazine we can use in the cases of motion sickness. Now we are going to understand about the second generation antihistaminic drugs. So what are the problems we are having? What are the things we are having? First generation, they are causing sedation in the patient. Patient is feeling sedated. Patient is feeling drowsy. So what we need to do? We need to give some drugs which are not causing sedation, right? Remember, they are going to be more potent than first generation. They are second generation, right? And they do not cross blood-brain barrier. They do not cross, or there will be, you can remember, less crossing. In fact, you can remember there will be less crossing of blood-brain barrier. Less crossing of blood-brain barrier means it will be going less in the blood-brain in the brain. If it is going less in the brain, it will be causing less sedation, right? So these are the drugs which are going to be less sedating. These are the drugs which are going to be less sedating drugs. Okay, and one more important property you can remember. Are they going to cause any anti-muscarinic effect or anticholinergic effect? No, they do not cause. They do not cause, or they do not block. You can remember they do not block muscarinic receptor. Muscarinic receptor. Okay, so in this particular class, the first important drug that we are having is going to be your cetirizine. Most commonly, you guys are using cetirizine, right? So you are having the drug that is going to be your cetirizine, very, very important daily use drug, right? The cetirizine, remember what this cetirizine is going to do. Some when you are going to take, remember in the sometimes you are also taking it in the cases of rhinorrhea, right? You are having running nose. What it is going to do, remember running nose is happening because of vasodilation. I've told you, whenever the vessel is dilated, something will be coming out, that is the water which is coming. And for the symptomatic treatment of viral kind of a flu, what you will be doing, you are using this particular cetirizine, right? So this cetirizine is going to cause what? It is going to cause what? It is going to cause blockade of histamine. It is going to block the histamine. And remember, histamine has a two function. It is going to cause bronchoconstriction. It is going to cause vasodilation. So if you are using cetirizine, what will happen? This histamine will be blocked, this vasodilation will be blocked, and you will be having what? Correction of the symptoms. That is what is we are doing in the cases of common cold or cough, right? In the cases of common cold that we are having because of the viral illness, and that is the symptomatic treatment. The ultimate treatment I've taught you in great details in classes. What is that? We are giving viral infection patient, we are just giving the water to the patient. That is going to be the ultimate treatment, right? So for this particular cetirizine, remember this is going to be a derivative of hydroxyzine. This is going to be a derivative of hydroxyzine. And sometimes this particular thing has some crossing of blood brain barrier, and that can lead to sedation. That can lead to sedation, like 30-40% people, they are sedating because of the cetirizine. They are feeling sleepy or drowsy. Not everyone, but some people are feeling drowsy or sleepy. And the dose, you can also remember, we are giving 10 mg, right? That is going to be the thing, right? For second drug we have developed, because this is going to cause what? This is causing what? Dizziness, or sorry, this is causing what? Sedation in the patient. What we have developed, we have developed levocetirizine. And this levocetirizine, remember, less dose is required. Less dose is required, and it is more better. Remember, it is better than cetirizine, because it is the derivative of cetirizine. Levocetirizine is the derivative of cetirizine. So this is going to be better than cetirizine. Better than cetirizine. What is the dose we are giving? That is going to be your 5 to 10 milligram. We are giving less dose, and we are getting the better effect. So which one is better, levocetirizine or cetirizine? Definitely levocetirizine is going to be more better, right? Apart from that, you can also write it about drugs like fexofenadine. 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 Remember, this is going to be the least sedating drug. Least sedating. We are having other drugs like loratadine, desloratadine. We are having loratadine, drugs like desloratadine. Remember, this is in fact overall the most powerful antihistaminic drug. Most powerful antihistaminic drug, that is going to be your desloratadine antihistamine. Okay, then we are having drugs like rupatidine. This is going to work via another property also apart from the histamine blockade. It is also going to block platelet activating factor. Important platelet activating factor, and that is what is going to give you one more anti-inflammatory effect. One more positive effect, that is going to be anti-inflammatory effect. So if they ask you which one is going to be the anti-inflammatory along with the antihistaminic, that is going to be your rupatidine, right? Then we are having drugs like azelastine. and olapatidine. Olapatidine. Remember, these are the drugs we are using for topical uses. Topical uses. These are the drugs we are using topically. So what are the uses, if I want to talk about the uses of these antihistaminic drugs before discussing the gout, right? So what are the uses of these antihistaminic drugs? The uses, they can be used in the cases of urticaria. And the most characteristic lesion that you are finding in the cases of urticaria is going to be your wheal formation, right? Wheal is going to be edematous. That means edema will be there. Erythematous. That means redness will be there. And itchy lesion. Why this itchiness is there? Because of histamine. Why this edema is there? Because of accumulation of fluid, right? Why this erythema is there? Because of dilatation of the vessels, because of histamine, vasodilatation, right? So urticaria, the drug of choice that you would like to give is going to be your antihistaminics. Patient is having allergic rhinitis, running nose, allergic rhinitis, right? Patient can have conjunctivitis, allergic redness in the eyes, redness in the redness or watery discharge coming from the eyes or nose. The drugs will be antihistaminics. If the patient is having atopic eczema is what? Inflammation of the skin. That is going to be dermatitis, a type of dermatitis, right? Side effects, normal side effects will be there. It can cause nausea and vomiting. Apart from all the side effects that we have seen, apart from that, it can also cause nausea and vomiting, right? So this is what pretty much you have to remember about the antihistaminic drugs, right? So these are the shortest question we are having. Now the next question that we are going to discuss is about the gout. Is about the gout. What is the presentation you will be getting in the patients of gout, right? If it is a clinical based question, or if a patient is coming to you, what you have to remember, this is going to be an alcoholic patient. A middle-aged alcoholic patient will be there. He's taking alcohol, right, along with the dry fruits or nuts, right? He's drinking, and he will be having involvement of metatarso-pharyngeal joint, or you can also say big toe. Big toe involvement will be present over there. Okay, and in question they can also write you negative birefringent needle-shaped crystals will be there. Inflammation of toe, needle shaped crystals, birefringent. That is going to be the presentation you will be getting. Middle aged alcoholic businessman person, right? That is going to be the gout. Okay, so gout is formed from urea or uric acid. If I ask you, gout is because of uric acid, not urea. And uric acid is the coming from the metabolism of what? Nucleic acid. And what are these nucleic acid? You can remember, nucleic acids are your purines, right? These purines are going to make what? Xanthine. These purines are going to make what? Xanthine. And this particular xanthine will be acted upon by an enzyme, xanthine oxidase. The name of the enzyme is xanthine oxidase. And this xanthine oxidase is going to make what? It is going to make uric acid. And now this uric acid, which is going to get accumulated in the body, this is known as gout. This is known as gout. Normally, this uric acid should be excreted. Normally, this uric acid should be excreted from the body. Uric acid is a toxic form, right? It should be excreted from the body. If it will get accumulated, you will be having problem, right? So what we can do, how we can remove, what is the problem we are having? The problem we are having is accumulation of uric acid. The problem we are having is accumulation of uric acid. So if we are having accumulation of uric acid, we know the pathway how to stop it. So I can do one thing, this I can block this particular xanthine oxidase. So what is going to happen? You will be having this xanthine formation, but there will be no uric acid. So first thing I can do, I can decrease the formation. I can decrease the formation of uric acid. I can decrease the formation of uric acid. Second thing I can do, I can increase the excretion. Second thing I can do is I can increase the excretion of uric acid. Some drugs are going to increase the excretion of uric acid. And third thing that we have identified in the birds, so this uric acid is going to convert into one form that is known as allantoin. So whatever birds droplets are droplings are coming. So what are these particular things? These are allantoin. Birds are excreting what? Allantoin. And remember, allantoin is non-toxic. So this uric acid is converted into allantoin with the help of an enzyme that is known as uricase. So this enzyme is absent in the humans, right? This enzyme is absent in the humans, uricase. So we are giving this particular enzyme to the humans, right? We are giving from the outside, and now what is happening? That excess of uric acid is going to convert into allantoin, and this allantoin is going to come out normally, right? So we are having three things. I can decrease the uric acid by three things. First thing, decrease formation, increase excretion, or conversion, metabolism conversion will be there. That is going to be your uricase enzyme. So these are the three modalities that we can discuss, right? So if someone is coming to you with the pain of acute gout, if someone is having acute gout situation, acute gout patient will be having pain, right? And for the painkiller purpose, what you will be giving, patient will be having pain along with the inflammation also there, along with the inflammation also there. What you will be giving to this particular patient, the drug of choice will be indomethacin. Never answer aspirin. Endomethacin, remember, it is having multiple mode of action. Endomethacin, aspirin is going to increase the uric acid, so you have to remember, right? Aspirin we are not giving. Aspirin is avoided. A for aspirin, A for avoided in gout. Aspirin is avoided in gout. Okay, so the drug of choice is going to be your indomethacin. If the patient is not getting corrected with endomethacin, what you will be giving? You will be giving colchicine to the patient. Colchicine, colchicine, colchicine. And remember, this colchicine is the most effective drug in the cases of gout. If someone is having gout, this is going to be the most effective drug. Most effective drug. It is going to inhibit the migration. It is going to be the most it is going to be the most effective drug. It is going to inhibit the chemotaxis. Chemotaxis, right? But there are certain side effects that we have to remember. Why we are not using it? Because of its side effect profile. What are the side effects it can cause? It can cause diarrhea in the patient. It can cause myopathies in the patient. Lastly, myopathies we have discussed in the last class with the fibrates, with the your fibrates groups of drugs, your statin group of drugs, right? Delayed myopathy, right? This is your diarrhea and myopathy will be there. It can also cause bone marrow suppression. It can also cause bone marrow suppression. It can also cause alopecia, because these are the drugs we are also using in the cases of cancer, right? So they are going to inhibit the cell division. They are going to work on the cell division, colchicine, right? So these are the side effects. That is why we are not using it. The drug of choice in the acute gout is going to be your endomethacin. Okay. For the chronic gout, what is going to be our approach for the chronic gout? For the chronic gout, we need to do three things. We need to understand the classification. We are having three things. First thing, we can decrease the formation. First thing, we can decrease the formation. How I can decrease the formation? With the help of certain things. What are these things? I can decrease the formation with the help of, first thing I can do, inhibition of this enzyme, particular xanthine oxidase. This xanthine oxidase enzyme inhibitor. Xanthine oxidase is not there. What is going to happen? Is there any possibility this uric acid is going to form? From the xanthine, this uric acid is not going to form if this enzyme is not there. So I can block this particular enzyme. The name of the drug is going to be your allopurinol. Allopurinol. In fact, this allopurinol is going to be the drug of choice. But there are certain side effects of this allopurinol. It can cause hypersensitivity in the patient. It can cause hypersensitivity in the patient. It can cause Steven Johnson syndrome. It can cause orotic aciduria. So these are some side effects of the xanthine oxidase inhibitor. Second, one more drug we can use. new drug that is going to be your febuxostat. Febuxostat. You can easily remember it is going to be xanthine oxidase static. It is going to stop the xanthine oxidase, febuxostat group of drug. So what is the side effect that we are having? This is going to make what? If this febuxostat is going to inhibit this particular enzyme, what will happen? There will be increase in the levels of xanthine. And if there is increase in the levels of xanthine, you will be having xanthine stones. The patient will be having xanthine stones in the body, right? So that is the side effect we are having. Second thing I can do is increase in the excretion. So normally uric acid is excreted, right? I can do what? I can do increase in the excretion, and I can do excretion increase. These agents are known as uricose uric agent. Uricose uric agent. These agents are known as uricose uric agent. What are the examples? You have to remember first drug is going to be your probenacid. Probenacid. Second is your sulfinpyrrole. Sulfinpyrrole. Probenacid, sulfinpyrrole. Look, pharmacology is a subject. When you speak more, then you will understand, right? Then you will remember. Probenacid, sulfinpyrrole, and we are also having lesinurad. Lesinurad, right? These three drugs, probenacid, sulfinpyrrole, and lesinurad. Remember, both of them are we are not using in the kidney problem. If the patient not used in kidney problem or kidney failure, if the patient is having kidney failure, we are not using both of them, probenacid and sulfinpyrrole, but we can use lesinurad. Lesinurad can be used in kidney failure as well, right? What is going to be the side effect? If this uric acid is going to come out from the kidney, you will be having urate stones. You will be having formation of urate stones. That is going to be the side effect. That is going to be the side effect. Last class we are having is going to be your drugs which are going to increase the metabolism. The drugs which are going to increase the metabolism, these are the drugs. We are having drugs like ras buricase, pegloticase, ras buricase, uricase, pegloticase, pegloticase. Okay, so these are the drugs we are having: rasburicase, pegloticase. Can you appreciate both of them are having this uricase type of enzyme, right? This uricase enzymes are the enzymes we are giving from outside to convert this uric acid into allantoin, right? This is the third method we are having. So this rasburicase is going to cause a side effect, that is going to be it can cause hemolysis. Hemolysis in G6PD deficiency patient, G6PD deficiency. Whereas the pegloticase, remember, it is the longest acting drug. Longest acting. We are giving it IV like twice in a week, right? That is going to be longest acting. And also remember, this is the drug which is the fastest urate lowering agent. These are the fastest urate lowering agent in the cases of tumor lysis syndrome. Tumor lysis syndrome. So you can remember this fact. So these are the drugs we are using in the cases of increased levels of uric acid. And what we have studied till now, let me just summarize also all the other drugs which can cause uric acid. First of all, you need to remember the drugs which increase uric acid. What are the drugs which can increase uric acid so that you can remember? First drug I have taught you is about the aspirin today itself. We are never giving aspirin in the acute gout. Acute gout, the drug of choice will be indomethacin. Chronic gout, we are going to give allopurinol. Okay, so first thing is going to be aspirin. Then we have studied about the loop diuretics. Remember, they are also diuretics. They are also causing what? Hyperuricemia. Hyperuricemia, right? Then yesterday we have discussed about a drug that is niacin. It is also causing what? It is also causing increased levels of uric acid. It is also increasing HDL, decreasing all other lipids. Then one more drug we have discussed today, that is the HCQS hydroxychloroquine, which is going to cause macular edema, bullseye, right? And TB drugs like pyrazinamide, or also isoniazid, you can remember. In fact, it is also causing the hyperuricemia, right? So these are the drugs which are causing hyperuricemia. You have to remember them, right? So this is pretty much about the uric acid. And what is happening in the cases of gout? Gout will be more uric acid. You need to decrease uric acid. Three things we can do better. First thing, we can decrease the formation. Second thing, we can increase the excretion. Third thing, we can do the alteration of the metabolism. Drugs like rasburicase, drugs like pegloticase. Here you will be using what? Here you will be using allopurinol or febuxostat. And here you will be using lesinurad, sulfenpyrrole. And one more drug we have discussed, that is going to be your probenecid. Right? So this is what pretty much you have to remember about it. Thank you so much for your patience. Right? These are our Instagram, Telegram, and like social media handles. You can always connect with us. This is the site where you can download your application for the Oracle. Thank you guys for all the patience.